This episode is brought to you by the Weather Channel app. Did you know the app can help you forecast more than just the weather? With allergy tracking and flu risk mapping. So you know when to stay inside and load up on podcast. As well as air quality and UV indexing. So you know when to get outside, load up on sunscreen and podcast. Forecast more of what you love with the Weather Channel app.
Hi, my name is Travis McVeigh. I'm an anesthesiologist from Dallas, Texas. I host a podcast called Thank You Notes at Ars Longa Media. Showing gratitude to people just makes me feel good, and I want to share the practice of thank you notes with everybody who listens. I write thank you notes to people and then bring them on the show to read it to them. Past guests have included my high school teachers, my friends, other physicians, and a couple of internet celebrities. I will also be doing episodes that explore the science behind gratitude practices to demonstrate to everybody the actual tangible benefits of practicing gratitude. Listen everywhere you get podcasts and check out the extras on my social media accounts. Thank you for listening.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
On today's episode of the ITB podcast, we are talking neurosurgery. We're interviewing Dr. Jonathan Rasouli, who is a neurosurgery resident at Mount Sinai in New York. And then we're going to go over a few neurosurgery related, at least kind of related questions. Before we get into that, though, I just want to remind you, complete your Doximity profile by December 30th, and you'll be entered to win a $100 Amazon gift card. Thanks to Doximity's Residency Navigator. Just follow the link on this show's webpage, insidetheboards.com/episode 016, all numbers, or go to docs, that's dox.im/insidetheboards to enter. If you're enjoying this podcast, I would really appreciate you either leaving me a review on iTunes or your favorite podcatcher and give me some suggestions on how I can make this a better learning experience for you. Suggest people you'd like to have interviewed for the show or what topics you'd like covered in future episodes. I'm very open to feedback. I would also greatly appreciate it if you would share the podcast on social media or with your friends. You can follow us at Boards Insider on Twitter or on Instagram and Facebook /Inside the Boards. But it would mean a lot to me if you find this useful, if you were able to spread the word. Just know that I would greatly appreciate it. So without further ado, let's look at some neurosurgery questions. These questions are taken from the Open Osmosis platform. First, a 35-year-old man is brought to the emergency department in a state of depressed consciousness and has a Glasgow coma score of 6. According to his wife, he had come home the night before with headache following a car crash where he rear-ended another car. His wife says he did not want to go to the hospital and instead took alprazolam to help him fall asleep. He expires in the emergency department. Which of the following is the most likely diagnosis? A. Epidural hematoma. B. Subdural hematoma. C. Concussion. D. Idiopathic intracranial hypertension. Or E. Subarachnoid hemorrhage. And the answer is B. Subdural hematoma. On the board exams, whether it's a neurology shelf, step 2, emergency medicine shelf exam, etc., you have to know the difference, how to diagnose the common imaging findings, and some of the anatomy involved in subdural hematoma and epidural hematoma. So a subdural hematoma forms between the dura mater and the arachnoid membranes. Head trauma is a common cause of subdural hematoma, especially in elderly patients. It is caused by tearing of the bridging veins that drain from the surface of the brain into the dural sinuses. In contrast to its cousin, epidural hematoma, there is a progressive neurologic decline into coma. It is diagnosed on CT scan when there is a high-density crescentic or moon-shaped collection. Some of the essential things you have to know related to a subdural hematoma are the CT findings. So crescent-shaped, concave, hyperdensity in the acute setting, and this is important, that does not cross the midline. And because the CT findings in epidural versus subdural hematoma are so important to distinguish because they are very likely to show up on a board exam, it's useful to come up with perhaps your own sort of memory aid or mnemonic. So 2 things you can do to help you remember the differences between subdural and epidural hematoma. So in my mind, I think of an elderly person driving a car at nighttime under the moon, right? Nighttime. And the sort of whiplash injury that occurs during a car accident tears the bridging veins. So I've just kind of associated my own mental picture of what a person who is afflicted with a subdural hematoma would be doing at the time they suffered that disease, to help me remember that the clot on a CT scan of a subdural hematoma is going to be crescentic or moon-shaped, right? So the second strategy is for related diseases that sort of have some overlapping features, but for which you really need to differentiate them and not confuse them, is the advice that I once heard from, I believe it was Golian, and that is, if you can't remember both, remember one, and the other one is the other one. And that seems kind of obvious and trite, but if you have a tendency to get confused about items that kind of fit into a comparison table, just memorize and study one of them and know it well, and essentially, for the most part, ignore the other one. If you encounter a question about entity number 2, if it doesn't match what you remember about entity number 1, you can rule it out. Create a mental picture as a mnemonic. Use what works for you. I like words, so etymology helps me. You could even add in your mental picture that as this elderly person is driving at night, they're over a bridge when they get hit, causing a tear in the bridging veins. It's those sorts of things that can help you memorize information. Let's look at the other answer choices. So A, epidural hematoma. Suffice to say, a whiplash injury with its sudden acceleration or deceleration tends to cause tearing injuries to veins as opposed to arteries, which is the structure affected in an epidural hematoma. But we're going to get a little bit more into epidural hematoma later. Epidural hematomas are commonly caused by discrete trauma to the lateral side of the head, but I'm going to leave that for now because we'll get into it more with the next question. Answer choice C was concussion. So a concussion is a alteration or loss of consciousness due to head trauma, which is characterized by confusion and amnesia. D was idiopathic intracranial hypertension, also known as pseudotumor cerebri. This most often presents in obese young women and is not precipitated by trauma. On the boards, a younger woman with headache, obesity, increased ICP, papilledema has idiopathic intracranial hypertension. Another kind of, associated symptom is a sixth cranial nerve or the abducens nerve palsy. The sixth cranial nerve allows you to look laterally, so a person who has that palsy won't be able to do that. And it's diagnosed by an elevated CSF pressure on a lumbar puncture. Answer choice E was a subarachnoid hemorrhage. This was discussed in last week's episode and often presents with sudden severe headache, thunderclap headache it's often called, or the worst headache of my life. It is generally caused by rupture of an aneurysm, as well as headache can also have meningeal signs like neck stiffness. And just as a reminder, if subarachnoid hemorrhage is suspected, a CT without contrast is the first step in diagnosis to look for blood in the subarachnoid space. If it is negative, but there's still a high index of suspicion, The next step in management is a lumbar puncture to look for xanthochromia or red blood cells in the CSF. And xanthochromia is that yellow discoloration of the normally clear cerebrospinal fluid due to breakdown of essentially red blood cells within the subarachnoid space. All right, let's move on to another question. A 23-year-old man comes to the emergency department after falling and sustaining a head injury 1 hour prior. His friends state that he was skateboarding when he fell and struck the left side of his head against a wall. He was initially alert, but became unconscious 30 minutes after the incident. Examination shows minor scalp abrasion at the site of the injury. A head CT is obtained. Which of the following is the most likely diagnosis? A. Parenchymal contusion. B. Epidural hematoma. C. Subdural hematoma. D. Traumatic subarachnoid hemorrhage. Or E. Toxoplasmosis. So, as you probably gathered, this question's correct answer is epidural hematoma. The features that make this stand out are all in this vignette. So the 23-year-old man has trauma to the side of his head. Epidural hematoma is classically the result of a temporal skull fracture leading to an arterial bleed into the epidural space. And this artery, the middle meningeal artery, is the one affected and the one you have to know. Next, this patient was initially alert, but became unconscious 30 minutes after the accident. So in contrast to the progressive depression in consciousness associated with a subdural hematoma, an epidural hematoma has a classic lucid interval, it's called. The people who suffer them, they seem fine, but then boom, not fine. With epidural hematomas, the bleeding is between the dura and the skull. And just like subdural hematoma, it's diagnosed by a CT scan with a characteristic blood clot that is described as a biconvex or lens-shaped or lenticular hyperdensity that does not cross the suture lines. So on the boards, somebody with severe trauma to the lateral side of the head who loses consciousness but then wakes up, seems fine, has a lucid interval, and then rapidly deteriorates. Things you need to remember are it's an epidural hematoma. On CT scan, it's biconvex or lens-shaped, doesn't cross the suture lines, and is the result of injury to the middle meningeal artery. And based on some of the feedback I've got, people like the podcast to be a little bit on the shorter end. So since the main learning points today are subdural versus epidural hematoma, we will leave it at that to give time for our interview. And like I said before, please, if you have the time and you enjoy this and it's helpful, give me feedback and share the podcast on social media. Welcome to the Match Smarter segment of the Inside the Boards podcast. We've teamed up with Doximity to connect you with program directors, residents, and applicants from top programs to help you navigate your specialty choice and the residency process as a whole. Check out the Residency Navigator at residency.doximity.com to get the most transparent and useful advice on programs you're considering. Doximity, the leading professional network for doctors. Match smarter with Doximity's Residency Navigator, residency.doximity.com. That is really difficult to say. All right. So, Dr. Jonathan Rasouli is a fifth-year neurosurgery resident at Mount Sinai in New York. He completed his undergraduate medical education at the Albert Einstein College of Medicine. Jonathan, thanks for taking time to offer your perspective on neurosurgery as a specialty.
Absolutely.
First thing I want to ask you, what does it take to be a neurosurgeon?
That is a great question. To be frankly honest with you, something I hear pretty much all the time from, interested medical students, from interested high school students, from interested sub-Is who are doing rotations with us. I always say it every single time, what does it take for me to be a neurosurgeon or even a neurosurgery resident? And, I would say there are a couple of factors or a couple of traits that we always look for in the people that are applying. The main things, the list can go on and on and on forever, but the main things that we're really looking for are people who are very committed and thrive in an environment of fast things happening right before your eyes, kind of a high stress, high reward, high risk environment. People really want to go for that challenge, really want to seek and really thrive and excel in that kind of environment, kind of a high pressure, kind of a high stress environment. If it's something that you really enjoy and really like, then neurosurgery is really very much a field for you. We also look for people who have a very high attention to detail as well, too. We're very, as neurosurgeons, we're very detail-oriented people. And every little thing we tend to overanalyze and sometimes even obsess over. So
yes, if I recall, there are a lot of sulci in the brain.
right, exactly. And trust me, by the time you're done with neurosurgery residency, you'll know all those things. You'll know it better than your own phone number, believe me. And really, probably, of course, those are some of the traits we look at, but we also look at people who are very much people who kind of put, and I kind of hate to say this, but there are people who kind of are willing to do whatever it takes to get the job done. Meaning, if that requires you to stay in the hospital a couple more hours just to make sure a patient gets a CAT scan safely, or to make sure that patient makes it to the OR safely, you're willing to do it. And really, no job is really something that you can't get done. Somehow that neurosurgery resident, no matter how big, how complicated, how difficult the task is, they will get it done. Those are kind of the traits we look for in people.
Okay, fair enough. So what do you consider the three most important aspects of a residency application in neurosurgery?
To just give you a little anecdotal evidence. So when I was a medical student applying for neurosurgery residency, it was very difficult to just looking through the internet and looking through forums and basically everything that was available at the time. It was just hard to kind of get a sense of what were the most important things that these programs were looking for. And it was kind of hard to know what exactly was it that I should really focus my application on. Was it, should I focus on my scores, my academic performance? Should I focus on, my letters of recommendation, my extracurricular activities, just the list goes on and on and on. Anyway, so I would say if the three most important, now that I'm, more senior resident and I'm actually now involved in the process of selecting applicants, I can tell you the three things I look for and the three things that I would say in general, most of the attendings I work with and most of the people who are involved in the residency selection process are looking for. I would say, no, and this is really no particular order.
Sure.
These would just be the top three. One, obviously, would be academic performance in medical school. We really want to see high board scores. We want to see good performance in the first 2 years. With the more didactic years, we want to see good grades in your clinical years. And in particular, for neurosurgery, we want to see that you did well in the surgery clerkship. I mean, that pretty much goes without saying. That would be kind of, I would say, in many cases, would just be kind of an initial filter. If you can get past that filter, then the other things we look at, and these are just as important, would be number two, I would say your letters of recommendation that you would obtain from rotating with your school's neurosurgery program and the programs that you may do away rotations at. We really want to see solid letters of recommendation from other neurosurgeons in the field, preferably neurosurgeons that are well known. Meaning, generally when you do an away rotation at a hospital, you will get a letter of recommendation from the chairman of that department. So we really want to see that, and we want to see like a good letter. And then number three, I would say the last thing would be your performance on those away rotations. We want to see that you do well, that you get along with the residents, you get along with the attendings, that you are knowledgeable, that you're kind of a go-getting personality, easy to get along with. That'll probably be the most important thing. Someone that we can say, oh yeah, he or she feels like, a resident here. It feels like one of us. That really is very important. Those would probably be the three things that we look for. Now, of course, I would say just number four, just there, but doesn't quite make number three, but it's just there, just underneath, is, I would say, your research. It's definitely important, but we would never discount somebody's application because they lacked research. If those three things are in place, it wouldn't even really factor in.
Okay, so you mentioned letters of recommendation as being an important component. How do you select the people that you want to write recommendations, have right recommendations for you?
Great question. So, I would say this. In general, the way the application works is you will have about 3 letters of recommendation that you can give. Number 1 should be the chairman of your medical school's hospital. Meaning, so I went to Albert Einstein, and the hospital is affiliated with my medical school is Montefiore Hospital, and the chairman there is Dr. Eugene Flynn. So no question, I should have a letter of recommendation from him, and that goes without saying for any applicant. You should have at least from your home school 1 letter of recommendation there. Your other 2, I would say, are up to you. You can either have another neurosurgeon, and I would say in that department, or maybe somebody you work with very well, write you a letter of recommendation, or you could just get those letters from your away rotations. When you do, let's say, an away rotation at, I'll throw out one. So I did one at NYU, and you can get a letter of recommendation from the chairman there, or even a neurosurgeon there. There's no, I wouldn't really say there's any difference between them. But if you did, I would say you should also have a letter if there was something unique about your application, like you did 2 years of research with some leading scientist or somebody who knows you very well. You should definitely include that, because that would be important in your application as well. So anyway, to recap what I just said, you definitely need to have a letter of recommendation from the neurosurgery chairman of your home school, and ideally 2 more letters of recommendation from either other away rotations, the chairmen from those departments, or neurosurgeons in that field who can be well known as well. That would be ideal. Last but not least, if you did some sort of like a year-long research, or did a lot of research with an individual who doesn't happen to be a neurosurgeon, you should probably get a letter of recommendation from them as well. So generally somewhere between 3 and 4 letters. You don't have too many.
Okay, fair enough. So what would you tell a student who might then be, say, a first year or maybe even like a pre-med, thinking, being a neurosurgeon would be cool, without trying to encourage any, anxiety or anything like that? How would you advise them to approach a plan to apply to a neurosurge residency?
Yeah.
From day 1 of medical school.
Exactly. I would say, to be frankly honest with you, that individual is a rare individual.
Okay.
It's definitely hard to sometimes to swallow that pill of kind of getting your application together for neurosurgery. But anyway, if I was going to go back in time, and if I could know what I know now, I would say you could do the following. I would say, first and foremost, you should get an idea of what neurosurgeons do in an OR. If it's possible, you should definitely try to reach out to some of the neurosurgeons at your home medical school and see if you can maybe go in a case and just see if it's something that interests you. And if it's something that you say to yourself, wow, this is the coolest thing I've ever seen. And to be frankly honest with you, that's how I was when I first saw my first neurosurgery case. Then you should definitely go for neurosurgery at like full force. I would recommend that if you can, it's not like super essential, but if you can get somehow involved with some of the research that's going on in that department early, that would be great. And if you can get your name on a publication while you're still in medical school, that would be fantastic too. There's not much you can really do in your first 2 years other than really just kind of rotate with the neurosurgeons there and get your feet wet a little bit, maybe get some research projects. But really your focus should be doing well in your courses and doing well on your boards. Once you're in your 3rd year, then you can potentially do some, if your school allows it, you should do some rotations with your neurosurgery department there. And ultimately, when you're in your 4th year, this is when you have the most flexibility and the most ability to actually show us that you're interested, would be to do like a month long or 2 months or whatever is, within the curriculum of your medical school to, come and join us on the service, let us know you. And ideally, if you've done some research and you kind of gotten to know the department at that time, then we kind of know you already, and it'll be like very seamless transition. Now, for somebody who, this is more my example, who became interested in neurosurgery later in their medical school career, I initially, when I started medical school, I wanted to do cardiology, which was kind of interesting. It's like totally on a different spectrum of
Yeah, for real.
but I became interested in surgery and then ultimately neurosurgery when I was in my third year clerkship. And at that point, I was a third year medical student, and I had felt that, my application could have been a little bit more tailored towards neurosurgery, because prior to that, I had done a lot of things related to cardiology, but really nothing in neurosurgery. So I decided to, and this is totally not necessary, but I'll preface it by saying that, but I decided to do a year of research with the Department of Neurosurgery at my home program between my third and fourth year. So when I completed my third year, I did a year of research with the department, and then went into my fourth year. And that's not required at all. It's just purely, if it's something that you'd be interested in, and I'm just kind of speaking hypothetically to, medical student might be listening. If you're interested in doing it and you really want to get some research under your belt, then by all means you should, consider doing a year of research, but it's totally not necessary. And if you can get involved in our department and in our program early on, then you're fine. I wouldn't even really worry about it.
Let me ask you this. How would you meet the objection to maybe somebody who has an interest in neurosurgery but just can't stomach the thought of a 7-year residency?
Yeah, it's so funny because I when I was really, I kind of struggled with the decision to go into neurosurgery. I thought to myself, like, man, 7 years, that is a long time. And do I really want to do that? And I just kept going back and forth. But what I ultimately decided, obviously I decided to go into neurosurgery. I thought to myself, if that's a field, if neurosurgery is a field that you can say to yourself, I just can't see myself doing anything else, then those 7 years will just fly by, really. Like, I'm in my 5th year now. I remember my first year of residency like it was yesterday. I can't even believe I'm in my 5th year now. It goes by that fast. So I would not discourage anybody from kind of negating neurosurgery as a field just based on the years alone. It is long, definitely, but if you're going to be a neurosurgeon, God forbid, if you ever need a brain surgery, you would want that guy to be like, like been through it all,
Absolutely. So, okay. Well, what other advice do you have for students who might be considering the specialty? Any other like really high yield points that you'd like to share?
Sure. I would say the big things, like I mentioned before, that we look at are your board scores, your letters of recommendation, and your performance on your away rotations. There tends to be, I wouldn't say that your boards, they're very important. I wouldn't say that, don't think to, don't not focus on it, but you definitely need to make sure your board scores are high. But there's a certain point, there's a cutoff for what we just want to see, kind of a minimum. And above that, it's not that important. So you don't want to get into this thing of, do I need to get 250 or 260 or 270? You don't want to be in that cycle. It really, I wouldn't focus too much on that. So just, try to do as well as possible.
Okay.
In terms of your letters of recommendation, they are very, 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 very important. There tends to be this kind of thought that, or at least when I was a medical student, one of the things I thought was, these things tend to be very generic form letters that, because when you're actually on the rotation, you don't, it's kind of odd. You don't often, it may be very possible that you don't really spend too much face time with the chairman there. And you wonder, like, wait, I didn't really see that chairman very often, but he's writing a letter of recommendation about me. Like, how is that possible? It seems kind of odd, right? But what happens is, just so you know what happens behind the scenes, the chairman will reach out to the chief resident of the service and will ask them, they get a list of all the people who did rotations there, and they say, hey, this person, Jonathan Rasouli, how did that person do on this rotation? Tell me about him. And that chief resident will say, oh, yeah, Jonathan was a great guy. He was fantastic. He was on top of things. He showed up early. You never want to be late to rounds. That's super key. It even goes in residence, anywhere. You don't ever want to. Yeah. But we note those things, if, that guy was late, it may seem trivial, but, we'll you don't want to be late. He was on top of things. Or they'll say, oh no, Jonathan, kind of lazy, didn't really show interest, didn't really want to get in the OR, da-da-da. And the chairman will write his letter based on that. So when you're on your away rotations, your focus should be to get along with the residents there as much as possible. Make sure they feel like you're part of the team. Make sure they feel like, you're enthusiastic, you want to get things done. You're not just kind of the word I'm looking for, kind of like a fly on the wall, just kind of watching things. They want to feel like you're integrated. Like, oh yeah, we can count on you. We can ask you to do things and get things done. And the more you're able to do that, and the more you're able to show that you're kind of a part of the team, the better your letter of recommendation will be. Because when they ask us ultimately, oh, how did this person do? We'll say, oh yeah, he was fantastic. It was great. We want him here, or want her here. We want this person here in our residency program. And your focus should be more on that, more so than I remember I would read up before cases and try to impress the attending, but with my they're not even going to remember who you are when that case is done. So, but the residents are always going to remember you. They're always going to remember what your performance is, and you really want to make sure that you do well there.
All right. Well, last question. Does it ever get old making jokes like it's not brain surgery or anything?
Never gets old. Okay. Never, ever gets old.
I figured. I had the sense of that. So awesome. Well, thanks for your time. And can people connect with you on Doximity?
Absolutely. Anytime. I'm more than happy to answer questions. I'm actually part of the neurosurgery interest group at Mount Sinai. So it's one of my personal interests is to help out medical students and kind of give advice, because it can be very daunting and very difficult and very kind of confusing to navigate all the information that's out there and kind of filter it down to what's key and important and focus on.
Awesome.
So, yeah, absolutely.
Well, ladies and gentlemen, Jonathan Rasouli, 5th-year neurosurgery resident at Mount Sinai. Thanks for your time.
Thank you so much, Patrick.
The music for today's show is thanks to The World is a Beautiful Place and I Am No Longer Afraid to Die. The song is I Can Be Afraid of Anything off Harmlessness. You can follow them on Twitter at TWIABP. That's The World is a Beautiful Place. Or check out their website, theworldisabeautifulplace.com. Thanks, guys, for letting us use the tune, and keep making great music.
Inside the Boards is in no way affiliated with the United States Medical Licensing Examination, Comprehensive Osteopathic Medical License Examination, National Board of Medical Examiners, the National Council of State Boards of Nursing, National Board of Osteopathic Medical Examiners, or any other licensing or examination body. All exam names and other trademarks are the property of the respective trademark owners. Content discussed during the program is the property of Inside the Boards or the attributed trademark owner and may not be reproduced without permission from the appropriate entity. Inside the Boards fully adheres to the respective policies on irregular behavior outlined by the aforementioned credentialing bodies.